Okay. Thank you for inviting me again. This is my second talk. So I'm going to talk about the clinical management of long COVID. So as I said in the morning, long COVID doesn't have good recovery rates. It has a high disability, and there is no effective treatment yet. So what we can do for all these people? Create a unit. It's not easy. This is our hospital, Trias i Pujol. It's in Badalona, near Barcelona. We said us that we are the long COVID unit. Can Ruti is the popular name to our hospital. And Lourdes Mateu is the head of this unit. This is, well, in Europe, but in Europe, in Catalonia, is a small region. It's not a country, but somebody wants to be independent, but it's in Spain. And it's really famous for, I don't know, Sagrada Familia of Gaudís, and for sure for the best ever football team, no? So remind Catherine, the woman that was 40 years old, she still has fatigue and asthenia since getting up in the morning. She has dyspnea when walking on level ground. He weighed 15 kilos since infection. She has palpitations with a care rate of 150. He has oppressive chest pain too, like anginal pain. She has joint pain, especially in the hips. She has 2 episodes of abdominal pain with diarrhea, mental fog with difficulty for doing 2 things at once, hypermenorrhea and pain, and again, negative thoughts about death. So we don't have effective treatments yet to cure, but we have to do something to these patients, right? So when we did the first visit in our unit, we tried to collect all the information in some questionnaires. This is one that we made. It's a Can-Ruti questionnaire. It's not validate for all the world, but for us it's really useful. And so many hospitals, not only in Catalonia, are trying to do it at the same time. But there are so many scales that are accept the post-COVID-19 functional status scale, the HODAS, which is the WHO Disability Assessment Schedule, and we pass so many scales like the Spanish version of EQ5D and the functional status scale. But why? Trying to know which is the impact in these patients and trying to compare, for example, year by year, if they are better or not. In our long COVID unit, for sure we want to do treatments to cure, but actually we are doing symptomatic treatments that are based on rehabilitation. Motor rehabilitation, respiratory, speech therapy, neurocognitive, and olfactory rehabilitations. But we can treat as a normal internal physician treatments by symptoms. What we do, maybe the letter is a little bit small, but in the first visit with the physician and, of course, nursing, we try to know which are the big problems for these people, and if we can, we derive to the specialized that we have in our unit. It seems that it's really useful and like, wow, wonderful, but the reality is another. It's true that it's not an easy ill, and so many specialized I don't like to see, but it's the reality. They don't like so much, these patients, because they don't know how to treat. And it's true, but we have to do it. Like in the first era of HIV, we have to do it. So if a patient needs for a cardiology, we derivate, for example, because they explain chest pain, that they can do anything. If they had inflammatory arthralgia, we perform an autoimmunity analytics, and we derive to the rheumatology, and all of these different type of specialties that we have in our hospital. But for example, we don't have the help of a neurologist. Sometimes we require, or a digestologist too. There are so many papers that trying to organize how to treat these patients, and based in other illness like chronic fatigue or fibromyalgia, They maybe are similar, and I think that we are on the top of the iceberg, all of this post-infection disease, that we are sure that when we find some kind of drug to treat COVID-19, we will treat too the other illness too, because there are a lot of people that are ill. So for example, if our patients has spots, it's a tachycardia, more than 90%, more than 90, so we can use for them beta blockers, ivabradine, and if they have symptoms of dysautonomia, we can treat with fluorocortisone or mirodrine. But it's only a guidelines, but there are not studies about these treatments. For example, the fatigue, some postulates to treat with coenzyme Q10, and for example, the autoimmunity, some new drugs, the name is BC007, that are in investigation. You have here the reference. This is from Davis. It's a physician that is really interesting in long COVID, because she has long COVID too, and their team publicates a lot of interesting papers about that. More or less are the same, all of this. So 2 important publications that I want to show you is that in our hospital, in our unit, some patients, as I said before, refers like a chest pain that for us, because we are internal medicine too, physicians, I mean, for us, this pain seems like they are doing like an angina, previous an heart attack. So we decide to do some different tests, like echocardiography, tomography, but they were normal every time. So finally, we decide to perform to them an MRI with adenosine, and we can demonstrate that these patients that had chest pain suffers for a subendocardial perfusion. So this is, for us, it was an important publication, not only for us, because we want the best for our patients, is to demonstrate that this is a real illness, that they have pain because there is a subendocardial dysfunction. I don't know what happened. Okay, sorry. But what more? Our patients has another term that the name is inappropriate sinus tachycardia, IST, that is a situation that in at resting moment they had a rate of more than 90 100 rates. No? So we analyze these patients, and we show that they have a lower heart rate variability in comparison with the uninfected subjects. So we postulate that there is a cardiac autonomic nervous system that is not okay. It's an imbalance that with a decreased parasympathetic activity, and this may explain this phenomenon. So to these patients, we give them cardiac treatment, like, as I said, beta blockers or ivabradine if they are not pregnant. So what about the clinical trials that I mentioned in this morning? 1 week ago, I find in clinical trials, and there are 312 studies trying to clinical trials in long COVID. So it's not bad, but recruiting at that moment only 107. So they are doing things, but where, no? This is important to know. I want to show you some of the, for us, most impact different clinical trials that are now at that moment. And maybe one day we will have the response for these patients. The plasma exchange therapy, it was a clinical trial, a randomized, double-blind. Plasmapheresis is like an apheresis of your blood. We performed 6 sessions versus placebo. It was not easy. We did in our unit. And I think in few weeks we will publicate the results, but we are not really happy on that. So it's important to know you that some clinical trials are not good enough because we have to avoid some patients that are without life, and they paid as they can to find a solution. The points of the treatments are antivirals and immunomodulators and other molecules. With long COVID, this is important. It's not only in a dark situation. There are people that are working on that. Paxlovid is postulated for treatment. Remdesivir, leronlimab, plitidepsina, ivermectina, baricitinib, anakinra, immunoglobulins, and other molecules like montelukast or fluvoxamina. Paxlovid, you know, we use in outcome patients with acute COVID-19, but there are 4 clinical trials that trying to show if can use for the long COVID. And they want to do Paxlovid during 15 days versus placebo. So 3 of them, are recruiting, but we don't have enough results yet. Remdesivir, as you know, too, we use for COVID-19, for acute COVID, and in ERASE, this study, he wants to use 5 days plus placebo to know if people has less long COVID. Leronlimab is a monoclonal antibody, is an inhibitor of CCR5, and it seems to be a good option to these patients. It's complete, but the treatment, we don't have this treatment, for example, in Spain yet. AER002, it's a monoclonal antibody too against SARS-CoV-2, and it's not yet recruiting, but they want to do a randomized double-blind. And plitidepsina. Plitidepsina is a marine-derived cyclic peptide that inhibits SARS-CoV-2 replication. So it's an antiviral and it's an anti-inflammation too. We want to use in our center, in our unit, but we have a lot of problems you know, with not the government, but with like FDA, no, sometimes but the similar in Spain, because they want to prove plitidepsina first in animals. So it's really difficult to do that because we want to continue, we want to run on these treatments, and now we are a little bit worried about that, but we will try to use this drug. Ivermectin is very used in COVID-19, but in long COVID, there are 3 clinical trials, and they use only for people that present anosmia or paranosmia. And finally, baricitinib. We hope that baricitinib may help us a lot. This is a destacate or an important study that is headed by Peluso. And they want to see if baricitinib during 12 weeks can modify the neurological symptoms in long COVID patients. Anakinra, you know that anakinra is an inhibitor of IL-1. It could be a possible treatment too. We will see if they are from the United States. And finally, the immunoglobulins for neurological complaints that we have to wait for the results. So I think that we have options, and I'm sure that the door is open for all these patients. Other therapies that are difficult or maybe more expensive or that is not really easy to have in our hospital is the hyperbaric oxygen therapy. There are some studies about this treatment. Another one is the fecal transplant. And it's because of the mechanism of the microbiota. And finally, the third one is the vagus nerve stimulation, that it could be non-invasive in the auricular ear or maybe invasive into the heart. But it's interesting because there are some treatments that some clinical trials that are trying to know if we treat these patients in the acute phase, maybe we can prevent the long COVID. And we have the same clinical trials with Paxlovid and with remdesivir. So it's good to know that maybe for sure, if we treat these patients in the acute phase, maybe they will not have long COVID. And finally, metformin. This is a really interesting paper. They tried the patients with 3 different drugs, with metformin, fluvoxamine, and ivermectin, and they show that outpatients treatment with metformin reduced long COVID incidence by about 41%. So the absolute risk reduction for metformin compared with matched placebo was 1.1%. It's a really good information to know. So thank you, Zicomo, and we will see.